Thank you very much. Oh, hi. Well, thank you very much. It's an absolute pleasure to speak to everybody again. So my title is No Brain, No Gain, and you're probably wondering, what on earth is that about? Well, basically, I'm going to speak to you about how does pain work, and the critical role of the brain in that. I'll also touch somewhat on medications, and if at the end of that you're able to understand how brains and pain work, it gives you the chance to continue to make gains. So that's the background to this. So, if you have EDS, hypermobility, you will be only too familiar with this, and this is this evil triad, as it's been nicknamed, that in joint hypermobility, regardless of the cause, whatever cause of EDS or other genetic cause of hypermobility, you can get pain around the joints, and that pain switches on physiological stress responses. That causes more pain in the muscles. The less you use the joint, the weaker the muscles get, the more deconditioned you get, the more unstable the joint gets, the more you can get the subluxations, dislocations, and it all feeds in on itself. And I'm sure most people here will be only too familiar with this sort of problem. So, first of all, what is pain? Now, you might think that sounds like a daft question and should be a very obvious answer, but actually it's much more complicated than that. So we can talk about acute pain. Now, that's the sort of pain that happens when you do have a dislocation, or stub your toe, or fracture something, or burn yourself. That's acute pain. That's that immediate pain from a traumatic incident. Chronic pain is very different. That's the sort of pain that just keeps going and going and going and just does not stop. And that sort of pain is typically very poorly responsive to painkillers, very difficult to treat, and this is the one that often causes the most problems with quality of life. And I'm pretty sure that for a lot of this audience, that's something you'll be very familiar with. So let's talk about acute pain then. This is the sort of pain that everyone will be familiar with. This is the sort of pain that we all can experience, whether you have EDS or not. So in acute pain, there's damage, there's trauma. That will activate pain receptors, and those receptors will activate those pain nerves. They will transmit signals onto the spinal cord. The spinal cord will then transmit those signals up to the brain. The brain processes that information and reacts. Ouch, there's pain. I need to do something about this. That will switch on behavioral and emotional protective responses, and I'm going to talk to you more about that. And it also switches on the fight-flight body stress response. Now, you may have come across that. That's the sympathetic autonomic nervous system. Pain has to switch that on. It's what it's about. And then once you've recovered from the injury and from the trauma, the body goes into a repair and rest phase. And the different side of the autonomic nervous system, that's when the parasympathetic side starts to kick in. So that's acute pain. We understand that much better, and our drug treatments are pretty effective for this sort of pain. That's not the case with chronic pain. So why is chronic pain so pervasive? And it's because pain is basically an evolutionary survival system. There are rare hereditary syndromes where you cannot experience pain. And they all have in common that you die early if you have those conditions. If you do not know you have a cut, and you do not know it's infected, you will die of sepsis. So if you cannot feel pain, your survival is shortened. That's how important pain is. But what does pain do? It signals danger. Again, if we take it back to evolution, if you're a rabbit, a caveman, a modern human, if you've got pain, in terms of evolution, that's danger. You're either going to have to stand and fight it, or you need to be terrified and run away from it, so hence the Monty Python. So pain has to switch on emotional centers, it's what it's about. So it can switch on anger and rage responses, but it can switch on fear, panic, terror. And these are all very basic, powerful emotions which are linked with stressful situations. So pain has to link with our brain stress centers. It's what it's designed to do, and it's what it's for. But what happens in chronic pain? Well, pain was supposed to be a temporary thing. So again, if we go back to evolution, if something damages you, you need a signal to stop you using that part of the body. That then has a chance to repair. You switch the signal off, you go back to using it. Evolution came up with pain. By does it work? But what happens if you don't switch it off? And we think that's what happens in a variety of different chronic pain syndromes, and we don't understand why, but you never switch it off, so it just keeps going and going. So now pain isn't about damage, it's not about trauma, it's about a brain system and a pain system that's defective. It won't switch off. So what sort of pain mechanisms are there in things such as EDS and in hypermobility from whatever cause? Well, there'll be some very obvious ones that we're all familiar with. So there will be biomechanical causes. So if your joint sublux and dislocates, you can get tendon trauma, ligament trauma. There may be, I've put a question mark by it, does it predispose to secondary osteoarthritis? That's wear and tear arthritis. The reason I put a question mark by it is we still don't actually know. One theory says because the joints are more unstable, there might be more damage, you might be more prone to early osteoarthritis. Another theory says, well, if you've got that elasticity and give, it's protective. So we don't actually know. And then there's the problem that a lot of people with EDS are just not very good at knowing where their joints are. It's the classic clumsy description. How many people here walk into doorways? Yeah, absolutely. So if you've got this problem that you're just not very good at knowing where the body is in space and the joints are in space, you're going to be more prone to injuries. So this is another factor feeding into it. Then there are musculoskeletal causes of pain. So the muscles themselves become very irritable and prone to spasms. And I know a lot of you here will have experienced that. If you've got a lot of pain and you cannot move the way you would normally do so, you're going to get what we call deconditioning. So the muscles are going to get weaker because you can't use them the way you normally would. The weaker they get, the more you have the joint instability. There may be additional problems that because you've got a weak and unstable joint, you can get more of the acute pain problems on top. So muscle damage, tendon damage, ligament injury. And sometimes if you've got a particularly problematic joint, the body naturally will try and compensate and adapt. But that means the way you walk, the way you stand, the way you move changes. And that means you're stressing different joints, different muscles, different tendons. So you can get overuse problems. So what happens in chronic pain? What actually goes wrong? Well, there's a lot of very complex language and terminology, as you can imagine. And I'm going to introduce you to a couple of complex terms that you may or may not have heard in things like pain clinics. So you'll often hear pain physicians talking about peripheral sensitization. Now, what does that mean? In the simplest terms, what it actually means is those pain receptors sitting on your pain nerves can fire more easily. And they can fire more often. So you can start to get a barrage of pain information coming from the nerves into the spinal cord. Now, there's a lot of very complex basic science around that. So there will be changes in how the pain nerves fire. So that's neurotransmitters, that's synapses and aspects like that. But the net result is you get more information from pain coming into the spinal cord. Then they'll talk about things like central sensitization. Now that's quite similar, but it's actually describing sensitization happening at the level of the spine and the brain. So those pain nerves come in and connect at the spinal cord. Those connections can also fire more easily, and they can also fire more frequently. So now you have a barrage of information going up to the brain, which has to deal with all this pain information coming in all the time. And it was never designed to do that. Now, the brain doesn't just sit there like a passive jelly doing nothing with pain. Again, in terms of evolution, if it did that, if you were overwhelmed, I don't know what that was. I think you're overwhelming the system here. So if you get overwhelmed by pain in terms of evolution, you'd be eaten. You wouldn't survive. So in terms of evolution, that's not helpful. So the brain is very clever. It can actually tune up pain. It can facilitate it, make it higher, increase the signal. But importantly, it can also decrease the signal. It can turn it down. And these are what we call the descending control systems. Now, when it turns it up, that's what we call facilitatory. When it tunes it down, that's what we call inhibitory. Now, it's thought in a lot of chronic pain syndromes, and there's a lot of evidence now, particularly in things like fibromyalgia, these descending controls, particularly the inhibitory ones that turn it down, these have been shown to be faulty in things like fibromyalgia and in a lot of other pain syndromes. So there's more interest now in understanding these descending controls. And if that isn't enough, you'll all be familiar that the pills just don't do much. They might take the edge off. That's a typical description from my patients. It takes the edge off. It doesn't make it go. So you're having to cope with all of that. And of course, we're all individuals. We all vary, so our stripes vary. And so that means that even in individuals, the pain mechanisms between us will vary. So what's happening for one person isn't necessarily happening for someone else. And furthermore, those pain mechanisms probably change over time. So what was happening early on may not be the same as 3 years later. So these things are dynamic and change. But have you also noticed how pain syndromes overlap? I'm sure many of you here, if you've got chronic pain, will have a number of other chronic pain syndrome diagnoses. You may have been diagnosed with fibromyalgia, TMJ pain, pelvic pain, irritable bowel syndrome, chronic fatigue. These aren't misdiagnoses. This is what pain does. What it's telling you is that these pain mechanisms operate across all of these chronic pain syndromes. So if these same mechanisms are happening, that's why you keep seeing these syndromes overlapping. So it gives you some idea of why we keep seeing this problem. And that leads to the concept of what's called centralized pain. And I think Dan Claw, who spoke yesterday, I'm not there, I was doing something else, unfortunately, but I know he may well have touched on the concept of centralized pain. Now again, putting it in its simplest terms, what that means is that in chronic pain, pain itself changes how pain works. So you can get more pain for less provocation. It's almost like someone's taken that volume knob of the pain, turned it all the way up, and left it there. And you are now stuck, tuned to pain at the high volume, and you can't change the channel. And that's what we're meaning by centralized pain. And it's this centralized pain that's at the background to all these overlapping pain syndromes. So I hope that gives you a little bit more understanding about the complexity of chronic pain. And all of that, I haven't even started to talk about the brain. And it's astonishing me that I've been working in the pain field for quite a long time now. But it's only relatively recently, I would say about the last 15, 20 years or so, that there's been any interest in pain community in what the brain does. It's all been focused on nerves, 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 and no one's taken any notice of the key importance of what the brain does with pain. And this illustrates that. Now, pain is an interesting sensation. Pain is something called aquellia, and aquellia is the correct term for the sensation of a perception. So your sensation of the color red is aquellia. Your smell of an apple is aquellia. The taste of an apple is aquellia. So these are sensations and perceptions. But the problem is, because they are sensations and perceptions, you can't compare them between people. I can never know if what I see as red is the same as what you see as red. Pain is aquellia. So it's a sensation and a perception. And that's what this slide actually illustrates. So those two pictures on the left are taken from something called the Thai Pasam Festival in Malaysia. And they take part in a religious festival and deliberately impale themselves with all sorts of things. Now, in any other circumstance, that would be exquisitely painful. And yet they apparently do not perceive pain. If anything, they're perceiving pleasure because they're taking part in this. And the cartoon on the bottom there, in Guantanamo Bay, that's torture. But in a German S&M parlor, that's pleasure. And yet, in all those circumstances, you have the same. If you come down to the basic science, it's your pain nerves firing, traveling up these systems, and yet how we perceive it and what emotions and how we respond to it is completely different. So the brain is absolutely critical to understanding pain. So I said I'd touch on medications. So, as you've probably gathered in chronic pain, there's no medication that will entirely remove the pain. It may tune it down a bit. It may tune it down enough that it allows you to have a better quality of life, a bit more control, but it's not going to make it all go. And I'm sure everyone here already knows that. So the critical thing with medication is balancing the benefits against the side effects. And you certainly don't want to be in the position that I have far too many of my patients, that you have a pain medication, you get the side effects, so someone gives you a pill for the side effects, which causes more side effects, you get a pill for the side effects, and it just goes on. And I have patients who are not uncommonly in 25, 30 plus medications. My record thus far is 45 plus. So what sort of medication do we use? Well, basically, there are two main classes we talk about. There are analgesics, which are your painkillers, and then there are what we call the neuromodulatory medications. So let me tell you a little bit more about those. So, analgesics. One of the simplest ones that everyone here will be familiar with is aminoacetafen, or as we call it in the UK, paracetamol. It's useful in that it has fairly limited side effects, obviously very dangerous in overdose. But yes, it's one that can be helpful, but it's quite a mild painkiller, so it may not have an awful lot of effect. Anti-inflammatory medications, that's the NSAIDs, they can be very effective in acute pain. So if you have a subluxation or a dislocation, the NSAIDs can be actually quite helpful there, but they're pretty rubbish with chronic pain. They don't prevent long-term inflammation despite their name, so taking them all the time, if you think that taking them all the time will stop inflammation, it doesn't. That's not how they work. The biggest risk with these is things like stomach ulcers. They can aggravate asthma, and there is a risk of, we think, a small increased risk of stroke and heart attack in anti-inflammatory medications. So if people have a history of heart attacks or strokes, then your physician will be extremely reluctant to give you an anti-inflammatory. Then we move on to things like weak opiates, and that's things like codeine and combinations of codeine. It took me a long time to realize that what M&M raps about Vicodin, it's what we call cocodamol. So it's a weak codeine combined with paracetamol. So yes, these can be useful for mild, moderate, and severe pain, but because it's codeine, codeine works through morphine pathways. It can have similar side effects to morphine, so constipation, tolerance, and unfortunately, like most medications, it can be open to addiction and abuse. So in terms of the analgesic medications, overwhelming advice, and I'm sure you've heard it, is the general advice is avoid the high-strength opiate medications. Or if you're someone that has to use them, keep them at the lowest possible dose you can, and you certainly need to avoid the escalating going up and up and up. Strong opiates are things such as tramadol, morphine, oxycodone, fentanyl. In some patients, low doses can be helpful, or brief doses for severe pain. So something like this might be a backup medication for a very bad dislocation that happens once or twice a year. But the huge problem with them is they are terrible anyway, and they are a lot worse if you have EDS. So these medications cause constipation, that's already a problem. They tend to lower blood pressure, that's already a problem. They screw up your memory, well, pain does that for you. They cause drowsiness, they do strange things to sex hormones, so they drop testosterone in men, we're still not sure what it does in women. It probably affects immunity. It can worsen pain, particularly high doses, and that's something we call opiate-induced hyperalgesia. And they can alter personality. If you take enough of the stuff, you still have the pain, but you don't care, but you're not you either. And of course, there are the problems with addiction and tolerance. So what are neuromodulatory medications? Well, these are things like the antiepileptics, so that's the gabapentins and the pregabalins. The idea with these is that they may help to reduce nerve, that's neuropathic pain, and some of them help with musculoskeletal pain. The biggest issues with these is that they can cause dizziness, drowsiness, and importantly, weight gain. It's a rare effect, but it's recognized. So I'm very cautious about these in people who already have a weight problem. The last thing I want to do is someone to gain several stone who already has problems. Antidepressant medications we use as well, such as amitriptyline, mirtazapine, duloxetine. And again, these may help with neuropathic pain, musculoskeletal pain. Additionally, they have the bonus, if it's necessary, that they may help stabilize anxiety and depression, and they may sometimes help with sleep. That's particularly the amitriptyline, nortriptyline group. But they have varying side effects, and some of the medications, such as duloxetine, is what we call an SNRI, can't be used with tramadol, or it can only be used with very small doses of tramadol, because there's a risk of a syndrome associated with that. Muscle relaxants. Well, again, the advice here is, if possible, don't use them, and if you do, keep the dosage down, and particularly the benzodiazepines, so that's the diazepams, need to be used with a lot of caution, and sometimes with quite close monitoring, Benzodiazepines such as diazepam are highly addictive. They should only be given in short courses. And the biggest problem is that when they're combined with opiates, the risk of accidental overdose and death with opiates massively climbs. So they need to be used with a lot of caution. And add on to that, if you take too much of a muscle relaxant, your already lax joints will fall out even more. So it's a difficult balance. Muscle spasms, so again, if you're using them, keep the doses short. It's not something you want to be on long term. And there's a lot of people don't focus enough on the non-drug methods of trying to help with muscle spasms. So really good relaxation, breathing, meditation, distraction technique can be brilliant for trying to help with muscle relaxation. There sometimes is a role for a muscle relaxant as an emergency backup for that really bad dislocation that might happen once or twice a year. Yes, sometimes they do get used like that. So overall, it's a balance of how medications help with pain against the side effects. So what are the problems I encounter in my clinic? Well, one of the ones is polypharmacy. I've already mentioned the patient with 30, 40, 50 plus medications. That's a huge problem. Most of these cause drowsiness, and drowsiness is already a problem in EDS, where you've got the sleep disturbance and the memory and the brain fog. Taking so much that you get to the point you don't care about the pain, but you don't care about yourself or anyone else by the time you've reached that stage. It blunts motivation, and people can become drug zombies. They're just not them anymore. So sometimes I get the opposite, where someone is so afraid of medication, they won't take anything at all, and actually just taking a weak medication might be very beneficial. So, what are my tips? One, recognize the limits of medication. It may help, but it's not going to make it all go. Aim to get the balance that works for you. If the side effects outweigh the benefits, why are you on the stuff? You need to keep a good relation with your general practitioner, family physician, because they're going to know a hell of a lot more about you than the specialist who maybe sees you once or twice a year. And they are likely to be heavily responsible for the prescription of these sorts of medication. For those people that are really struggling with medication, and particularly if they're on opiates, high-strength opiates, they may be referred on to a pain clinic for some specialist medication advice. Tips 2, opiates are regulated medications. There may be very strict rules about how much you can be prescribed and how often. Some practices I know use opiate contracts. I think it's more common in the US than in the UK, but it's also coming to the UK. And beware that what works for one person may not work for someone else. So be very careful about pill swapping. And also just be aware there's a hell of a lot of dodgy stuff out there on the internet. There are some good supplements, but there's some really weird stuff out there too. And it's not just pills. There are all sorts of strange machines and things as well. Some can be very good, some are just nuts. So beware of anything that says it's going to cure everything. Those are the ones to be very cautious of. And check if it interferes with your medication. Herbal supplements and other medications can interfere with prescription medication, so always check. So in summary, in chronic widespread pain, keep it simple. If possible, avoid high-strength opiates, or where they're being used, make sure it's the lowest dose you possibly can, that it's not escalating up, and you may need additional expertise and specialist advice. And that neuromodulatory medication can sometimes be helpful, again, provided side effects are not outweighing benefits. So above all, balance the benefits against the side effects. If they don't help, stop them. And don't become a drug zombie. You will still have pain, but you won't care, but you will not be you. And be aware of this too. If you were at the previous talk, if you have chronic pain 24/7, it's inevitable that, as we've already seen, how I've explained how the brain and pain work, it switches on stress and emotion centers. What it has to do. Therefore, if you have pain all the time, depression and anxiety are really common. This isn't madness. This isn't weakness. This is what chronic pain does. But if it isn't addressed, if someone's really struggling with anxiety, depression, it feeds massively into pain. Particularly anxiety, it feeds massively into the muscle stress responses. So if it's there and if it's significant, getting advice and input can really help. So Sometimes people do need some counseling. They may or may not need some drug treatment to just let you get some control back, but don't be afraid of it. This isn't, as I say, madness or weakness. It's what pain does. And if that's what it needs to help you get that control back, use it. So mind and body, you can't separate the brain from the body. People in chronic pain get depression and anxiety. We have good papers now showing that depression and anxiety is higher in EDS compared to non-EDS people. We've also noted that there are much higher rates of previous abuse, adverse childhood circumstances in chronic pain. Now that's really interesting, because what we're discovering now, and there's more work coming out of psychiatry, is people that have to survive adverse childhood circumstances, be that pain, be it abuse. You have to adapt. Your brain has to adapt to chronic stress. And those adaptations that get you through chronic stress, they have been shown in later life that maybe those adaptations, if you then encounter pain, cause problems. So there's a lot of very interesting work now, neuroimaging work, trying to understand how previous adverse childhood circumstances can predispose to pain later in life. Now, this work first came out of babies, premature infants. You may or may not believe, I often despair at the medical profession, that it wasn't that long ago it was thought that premature babies couldn't feel pain. Can you believe? I can't. So premature infants, about 20, 30 years ago, with all those painful interventions they had to have, the lines, the injections, the blood tests, they weren't given any painkillers, any analgesia. And so a lot of this work came out from the early studies with premature infants that were able to show that survivors of that, if you then looked longer term into adulthood, they had much higher risks of having chronic pain. So there's a lot of interesting work there. So the key message here is brain and mind and body matter. And why is it that so often doctors and patients think you can split one from the other? You can't. We are a whole person. You have to look holistically. We need to look at all of it together. So, overall summary, acute pain. We're much better at dealing with that. Chronic pain, much more complex. And I hope I've given you an overview of why that is so complex. It's really, really important to look at the individual and the pain mechanisms that are operating in that person at that time. Painkillers might help to reduce the pain to a point where you get better control, but they're not going to make it go. It's critically important to look at the non-drug aspects of pain and how you can improve rehabilitation. And I do a lot of that, as you gather. And physical rehabilitation and non-drug coping strategies are really important and very beneficial in chronic pain. And I hope maybe another time I can talk to you more about that. Remember the importance of pain, stress, emotion, how they all feed off each other, and therefore for some people, some of the psychology approaches can be helpful. And my tip there is don't be afraid of psychology and psychiatry. It's another tool in the box, but you have to find the right person that clicks with you. So if you've had psychology and it didn't work the first time, it's not that psychology may not work, it's that you may not have had the right person or the right type of psychology input. So just be aware of that. That's a little tip for you. And at that point, I'll throw it open for questions.
Thank you. I don't know.
It's a bit
surprises me every time. I don't know, would those of you who know how these things work check your phones, because I don't have any questions. I don't know, I've gone in and out. You have a question, I meant the app, but okay, let's start with you. Thank you.
Can you spell Aquellia for me?
Oh, Aquellia, Q-U-A-L-I-A, Aquellia, and you'll find philosophers such as Daniel Dennett talking on that. It's a really interesting bit of cognitive neuroscience.
I've got 2 questions on my app.
Right. Basically, one said, does anybody know what this is going to be about? And the other one said, yes, my question too. And nothing else has come in. It's making me wonder if there's a problem. So let's take questions from the floor. Yes, sir.
Is the brain or the mind handling chronic pain? Like, it seems that, like with my daughter, she's built a higher tolerance of pain. Is that in her mind, or is it the brain doing what it does?
So the question is it mind or brain operating in pain? The answer is it's both. If you want to be really reductionist, if you don't have a brain, you don't have a mind. So I tend to not differentiate between brain and mind. Consciousness, again, it's a huge area of cognitive neuroscience. How does consciousness arise? What is consciousness? That's a whole area of philosophy and cognitive neuroscience, but basically it's happening at a brain level. So the answer is it's both.
Oh, thanks. Hello. I work in pain management as well, and I do see EDS patients as well. One thing that we've seen success with, at least in Southern California, is ketamine infusions for patients with chronic pain. Infusion? Ketamine infusions.
Oh, right. Yep.
And so I wanted to find out what your thoughts are on the fact that it can help decentralize some of those chronic pain patterns and mechanisms that have become chronic.
So the question is about ketamine infusions. Again, the answer there is you have to be very careful balancing up potential benefits against side effects. So the ketamine has also been a treatment in complex regional pain syndrome, another area of my speciality, for a long time, but it's also been an extremely controversial area. Ketamine is an interesting molecule in that it works on what they call the NMDA receptors, which are key in neuropathic, that's nerve and spinal cord driven pain. And it definitely works at that level, which is why ketamine gets used for short but extremely painful procedures such as burns. It often gets used in the battlefield as well, so it gives a very deep anesthesia, but it gives pain-killing analgesia as well. It's also the main horse tranquilizer that you may or may not be aware of. But it means it's also incredibly powerful medication, and it's also very addictive. It's also metabolized through the liver, so some people can't tolerate it because it screws up liver function. Long term, it does very bad things to bladders. And ketamine addicts that are using street-bought ketamine and high doses ketamine for a long time can screw up their bladder completely and end up with having bladders removed. So like all things, you have to balance the benefits against the side effects. In CRPS, if it's used, it should be used in a short infusion. You would establish in that short infusion how much it helped. If it didn't help, you wouldn't repeat it. If it did help, depending on the pain clinic, you would then look at the intervals that you give it for. But then the question is, how long do you keep giving it? Do you keep giving it forever, or do you start running into the problems? So it's another very, very controversial area. I think if the occasional infusion, once a year, twice a year, maybe for a couple of years, helps, that's probably reasonable. But if you're ending up with 3, 4, 5 infusions that just go on and on and on, you're going to hit problems. And I can only give you an anecdote from my experience many years ago. As a medical student, a long time ago in the UK, when we used to have big old psychiatric institutions, I was doing a block in North Wales, so this is a pretty remote area of the country. And one of the psychiatrists there was trying to persuade the medical students to take ketamine so that they could unlock their conscious mind and record their subconscious experiences. So they were trying to persuade us medical students to take ketamine and do this. One of his colleagues, another psychiatrist, came up to us afterwards and said, "Don't do it. I did it. It was the single worst experience of my life." Because if you have a really bad trip, it's something else. So again, benefits have to be balanced very carefully against side effects. But yes, it does have a role. It does have very interesting analgesic properties, but it's an incredibly powerful medication. Have I got anyone directing?
Yep.
Oh, okay.
Gabapentin has been called into question here in the US lately, and the problem, I can't get online to give some things because that's why you can't see my question. So I'm wondering if you're aware of that and what your thoughts are on that.
Yeah. Gabapentin, another very, very interesting medication. It's actually just changed status in the UK. It used to just be a standard prescription medication. It has now been moved to the same category as opiates. And that's quite recent. That's from April this year. The main reason it's been shifted into the same category as opiates in the UK is it is now the #1 drug of addiction in prisons. And on the street. So like everything, just about anything you name is open to abuse. it astonishes me, but if you take handfuls of gabapentin, you can get a high. And in prisons, when it became harder and harder to get hold of opiates, they started abusing gabapentin. You can abuse pregabalin the same way. So pregabalin has also been moved into the same category. They can be very effective medications, but again, you have to balance the benefits against the side effects. The main side effects are the drowsiness and the dizziness, particularly at higher doses, and the weight gain. It's rare, but it's real. And I've seen too many patients that have been put on it come to me a year later and say they've gained 3 stone in weight, and no one had ever warned them that weight gain can be a possibility, so monitor your weight.
I've had CRPS, and I was wondering what your current treatment protocol looks like.
Well, there you go. I can probably reduce that quite simply for you because it's a very complex topic, but there are some extremely comprehensive guidelines produced in the UK called the CRPS UK guidelines. Basically, if you put into Google CRPS guidelines UK, it'll bring them up. And it's published through the Royal College of Physicians. There's a full version and a concise version. The full version is enormous, but it covers every aspect of CRPS you want to name, including the medication approaches, including the rehabilitation approaches, including the brain training approaches. It's all covered in there. So the quickest answer for you is look up the CRPS UK guidelines. Loads of information in there.
Come meet me.
I don't know, have you heard about NAD positive IV therapy?
Sorry, I didn't quite catch that.
Okay, NAD positive IV therapy.
No, NAD positive. I'm assuming that's referring to NAD, which is a molecule involved in these, the pathway, the metabolic pathway within mitochondria. I'm assuming it's part of the Krebs cycle, that sort of thing.
Yes.
No, I haven't come across it as a therapy in the UK.
Okay, in the United States, there are clinics. It started in Louisiana, and they're training, and it's starting to spread across clinics. And I was just wondering because I think you were talking about ketamine affecting NAD, but I was just wondering if you're going down farther on the pathway, because I do know that it does alleviate, the depression, PTSD, and then also can offer some relief with pain as well too for patients.
I would tend to say keep an eye out for the evidence. So you probably need it to be around a bit longer. Once you start seeing the papers coming out, giving you a good idea of exactly how much it's helping, but it'll also give you a good idea of what the benefits and side effects are. So everything has to start from somewhere. So this is probably in the early stages, but what you want to see is let someone else be the guinea pig, give it some time, and then see what the evidence is telling you, because that'll give you a much better idea of what you're going into.
Okay, I have 2 questions in maybe one. Do you know what are your opinions in nerve blocking when they go in here?
That's the stellate block.
Right, and the other one is how do I know if it's pain or I have to take it serious and it's something else because I'm so used to pain and I don't know when it's like, it's pain or is neurological signal that I have to do something about it.
Yeah. Well, stellate ganglion blocks are something done in pain clinics, usually done by anaesthetists, so it's usually anaesthetic pain clinicians. They do have a role in pain. They are used in things like complex regional pain syndrome. They're sometimes used in head and neck pain syndromes, but they also have benefits and side effects. Where you're putting the block is a really delicate area of the body. You don't want to get it wrong. There's a lot of important networks and nerves and stuff going on through there. So if you do have stellate blocks, you are usually warned about the adverse effects, including bleeding, clotting, paralysis, permanent numbness, et cetera, they will warn you because of where it's being put. Again, they should be used as temporary therapies. They're not curative. They may give you some relief for a certain amount of time, but it doesn't cure it. And they're usually things given again in short courses. They're not usually things that carry on forever. Now, there are some patients I know from the old days that have been having stellate blocks 3 times a year for the last 15 years. But there will come a point when it's so scarred and so difficult to do that the dangers outweigh the benefits. So typically, stellates are used for short-term relief in a short course, usually to help bridge while you're getting other treatments, such as physiotherapy and rehabilitation. So that's probably that side. And in terms of pain, unfortunately, there aren't easy answers. Basically, over the time, people tend to get good at learning to read their own body. What pain is normal for you? This is what you're used to, so that when something changes and is significantly different, then you can say, this isn't normal for me. This is where I might need to get some additional advice. But because we're all individuals, that's going to vary. So usually, I'm afraid it's time and bitter experience will give you that information.
Okay, something started popping up on my phone. Thank you ever so much. I told you I'm bad at this. I don't know why they let me do it. Okay, I thought I did. All right, sorry, don't want to waste your time. Have you done much study of neural retraining, neuroplasticity approaches to pain management?
Oh, absolutely, and that's critically key in all the complex regional pain syndrome work we do. But because our centre is so familiar with these techniques in complex regional pain, we also standardly expand those techniques to any sort of chronic pain, including some patients with hypermobility and with EDS. So if they have similar sorts of pain, so neuropathic pains, particularly if they have what we call allodynia. And allodynia is where touch isn't touch anymore, it's exquisitely painful. So just touching the skin is exquisitely painful. Now, sometimes you can get it in a localized area, so just in one area, and desensitization techniques can be extremely helpful for that. It's also common if you have chronic pain that everything gets sensitized. So the whole body is sensitive to touch and to pressure. And people will often report it's also sensitive to bright lights, loud noises, strong smells, and that's a sign that everything's wound up. So yes, neuroplasticity techniques, it's quite specialist. It's mostly come out of phantom limb pain rehabilitation and complex regional pain syndrome rehabilitation. It's probably too complex a topic to explain all about here, but suffice to say, if you've got the right person with the right sort of problem, yes, we do use those techniques.
Fibromyalgia. So, what have you found that's effective with that?
I'm sorry, I couldn't catch that.
Have you found anything effective with fibromyalgia?
Yeah. Again, fibro, when I see patients coming to us for consideration of our inpatient rehabilitation program, for those of you who aren't aware, we run the only inpatient rehabilitation program for EDS in the UK. And as far as I'm aware, I haven't come across that anywhere else in the world either. So I get a lot of people coming through with the bad end of the spectrum. So most patients, by the time I get to see them in clinic, if I wanted to, I could also diagnose them with fibromyalgia. Many have already got that label, but if I really wanted to, I could diagnose them with it as well. I often don't, because I'm just giving someone another label. And as we've already discussed, those background pain mechanisms are why it's there. So my overriding concern is to treat the patient. So the same sorts of techniques that we use for EDS, I use in fibro as well. So it's about balancing medications. Have we got it right? Not too much, not too little. Benefits outweighing side effects. But the critical bit that people miss is the non-drug approaches. So in fibro, again, it's about the right sort of rehabilitation, getting exercise at the right level. The classic is people trying to put, say, physio saying, oh, I've got fibromyalgia, get on an exercise bike and do half an hour. That's never going to work. It has to be pitched at the person at their level. You need to find your baselines. So what level of exercise can you do? You can do every day, and it's not killing you. That's your baseline. If that amount of exercise in the next day or next 2 days you can't move, you've got it wrong. You need to halve it. Once you've got your baseline, then you can start building it up. And again, everyone's going to be extremely variable as to what that baseline is. It's the right therapist, it's getting the muscles going, it may be using some of these neuroplasticity brain training techniques. It's whatever you can throw at it that helps the individual.
We're out of time. Thank you so much, Dr. Cohen.
Thank you.